Today we are going to start pediatrics, and the first topic that we are going to do in pediatrics is respiratory diseases, important respiratory diseases in pediatrics. The first of them is
Hello, Dr.
newborn
Shah. Can you, if you
respiratory
get some time, can you please explain
distress.
that pedigree? The one for
Oh
the,
yes,
yeah, I mean, it's okay if you have started, it's all right if you get in between some time. Can you please explain that?
okay. I'll explain it at the end or in between if we got time.
Okay, that's fine. Thank you.
Is that all right?
Yeah, that's fine. Yeah, that's fine. Thank you.
So, newborn respiratory distress syndrome. What is newborn respiratory distress syndrome? Newborn respiratory distress syndrome is mature babies who are born before 32 weeks of gestation. When a baby is born before 32 weeks of gestation, then enough surfactant is not produced in the lungs to keep the lungs open. So due to deficiency of the surfactant, the alveoli collapses and newborn baby develop respiratory distress. And the features with which, what are the features of respiratory distress syndrome? Remember that the diseases that we are going to discuss, such as respiratory distress syndrome and congenital pneumonia, meconium, aspiration, all these will have somewhat similar presentation. So, a newborn with SOB, grunting, tachypnea, interpersonal retraction, nasal flaring, cyanosis, low oxygen saturation. So, if these features are present in a newborn baby, then we will discuss suspect a respiratory problem. For example, SOB, grunting, tachypnea. So if these features suspect, due to insufficient lung surfactant, which leads to collapsed alveoli. Initially, SpO2, if a baby present to us with these symptoms, we'll check his SpO2 partial pressure of uh, saturation pressure of oxygen and blood gases, and then immediately a chest X-ray will be done. So initially SpO2 and blood gases, and then immediate chest X-ray whenever we are suspecting a respiratory problem in a newborn baby. And if now the first hint for respiratory distress baby will be premature, and the second hint for respiratory distress syndrome is that a chest X-ray will show bilateral ground glass appearance. So respiratory distress in a premature baby, and X-ray shows ground glass appearance, respiratory distress syndrome. What is respiratory distress syndrome? Premature infant, cesarean delivery, diabetes, meconium aspiration syndrome can also cause respiratory distress syndrome. Presentation will be respiratory distress, intercostal recession, tachypnea, expectorating, and cyanosis if severe. Investigation will be monitor oxygen saturation, arterial blood gas analysis, and then a chest X-ray. What will be the treatment of, you can see in this diagram that this chest X-ray, you can see that it's just like a ground glass. Both the lungs on a chest X-ray is giving the appearance of ground glass. So that is how it is diagnosed on X-ray initially. Now, what is the treatment of respiratory distress syndrome? Because the problem in the respiratory distress syndrome is deficiency of the surfactant. So endotracheal surfactant replacement will be done. Surfactant will be replaced, and also intermittent positive pressure ventilation will be given, and fluid and electrolyte monitoring will also be done. How we can prevent respiratory distress syndrome? Respiratory distress syndrome can be prevented by giving glucocorticoids to the mother before delivery, because steroids can increase the formation of surfactant. So if in the question they ask how to prevent respiratory distress syndrome, then your answer will be glucocorticoids. So we have discussed one cause of respiratory distress in a newborn infant, and that was respiratory distress syndrome. The two most important hints for respiratory distress syndrome is the baby will be premature, and the second one is there will be ground glass opacities or ground glass appearance, bilateral ground glass appearance on X-ray. Now, the second condition which can cause respiratory distress in a newborn infant is meconium aspiration syndrome. Meconium aspiration syndrome refers to respiratory distress in the newborn as a result of meconium in the trachea. It occurs in the immediate neonatal period. Now, what can cause meconium aspiration syndrome? Remember that meconium is the first stool that a newborn baby pass. So if the baby pass his first stool in the womb of the mother, then there are chances that meconium will be aspirated. It can only occur in post-term deliveries. Up to 44% of post-term deliveries are complicated with meconium aspiration syndrome, usually after 42 weeks. So the difference we can note here is that respiratory distress syndrome due to surfactant deficiency was common in premature babies. And meconium aspiration syndrome is common in post-term babies, babies who are born after 42 weeks. It can cause respiratory distress like respiratory distress syndrome. Some other risk factor for meconium aspiration syndrome is maternal hypertension, preeclampsia, chorioamnionitis, and smoking or substance abuse. These can all lead to meconium aspiration as well. So whenever, so the first hint for meconium aspiration syndrome is that it is common in post-term babies. Now, the second hint for meconium aspiration syndrome is that in the question, they will sometime mention that amniotic fluid is meconium stained. So meconium stained amniotic fluid in a baby who is presented to you with respiratory distress and he is a post-term baby, then your diagnosis will be meconium aspiration syndrome. Treatment of meconium aspiration syndrome is very simple because it is due to aspiration of the meconium. So airway suctioning is important and maintenance of oxygen saturation and again fluid and electrolyte monitoring. Why meconium aspiration occurs in post-term infant? Because as the fetus approaches term, the GA tract matures and vagal stimulation from the head and spinal cord compression may cause peristalsis and relaxation of the rectus sphincter, leading to the meconium passage. So because as the baby reaches the term, due to activation of the due to vagal stimulation, this rectal sphincter it relaxes and that can lead to the passage of meconium, which can be aspirated, which can lead to respiratory distress in the neonates. So respiratory distress in premature infants, you will suspect respiratory distress syndrome, and respiratory distress in a post-term babies, you will suspect meconium aspiration syndrome. How you will confirm your diagnosis? The other hint for both of these diseases, an infant with respiratory distress and X-ray show bilateral ground glass opacities. Again, your diagnosis will be respiratory distress syndrome. And if there is meconium stained amniotic fluid in a baby who is presented to you with shortness of breath or tachypnea or grunting, then your diagnosis will be meconium aspiration syndrome. The treatment of respiratory distress syndrome was surfactant replacement, while the treatment of meconium aspiration syndrome is airway suctioning. So far we have discussed two causes of respiratory distress in newborn. Now, the third cause of respiratory distress or tachypnea or shortness of breath in newborn is transient tachypnea of the newborn. So as its name indicates, it is transient. So it will resolve within 1 or 2 days, or sometimes it may take up to 3 to 4 days. So respiratory distress was common in premature infants, meconium aspiration in post-term infants, and transient tachypnea of the newborn is common in term infants. What is the cause of transient tachypnea of the newborn? The cause of transient tachypnea of the newborn is that when the baby is born, there's a delay in the clearance of fetal lung fluid after birth. Because the clearance of the fluid that is present in the lungs, so there is ineffective gas exchange, which can lead to respiratory distress and tachypnea. So transient tachypnea of the newborn is common in term infants. And the second hint for transient tachypnea of the newborn is that chest X-ray will show presence of fluid in the horizontal fissure. Fluid will be present in the horizontal fissure, and administration management is very simple. Administer oxygen. Usually no other treatment is required because the features of respiratory distress usually settle in a day, and sometimes it can go on for a few days. So there's nothing to worry about because it's a transient condition. It will improve itself. The only thing that you need to do is to administer oxygen. So far we have discussed three causes of respiratory distress in newborn: respiratory distress syndrome, meconium aspiration syndrome, and the third one, transient tachypnea of the newborn. Transient tachypnea of the newborn is common in term infants, and the X-ray in this case will show fluid in the horizontal fissure. There are some other causes of respiratory distress in newborn as well. Remember that whenever a newborn baby present to you with shortness of breath, or tachypnea, then you will suspect these causes such as respiratory distress syndrome, meconium aspiration syndrome, transient tachypnea of the newborn, and congenital pneumonia. So pneumonia is also in one of the differential diagnosis. And whenever a newborn present to you with these respiratory symptoms, the initial test will be SpO2 and blood gases, and then X-ray. And then after X-ray, you need to send blood culture and sensitivity, even if the fever is not present, because the absence of fever does not mean that there is no sepsis or there is no congenital pneumonia. So after SpO2 and blood gases and X-ray, the next step would be to send blood culture and sensitivity. X-ray is done in all the cases to rule out the other causes, because as we have seen that in respiratory distress syndrome there will be bilateral ground glass appearance, while in transient tachypnea of the newborn there will be fluid in the horizontal fissure. While in congenital pneumonia, because pneumonia is consolidation, so a patchy consolidation will be seen in the case of congenital pneumonia. That's why after SpO2 and blood gases, immediate chest X-ray should be done. But bear in mind that we will start the antibiotics as well until the pneumonia is excluded. Congenital pneumonia, that is consolidation, will remain as one of the differential diagnoses, and thus baby will continue receiving antibiotics until pneumonia is excluded. So if you are not sure about the diagnosis, then antibiotic need to be started until pneumonia is excluded. So in short, infant in respiratory distress, the causes can be surfactant deficiency, congenital pneumonia, meconium aspiration syndrome, transient tachypnea of newborn, diaphragmatic hernia, and pneumothorax. These are some causes of respiratory distress in a newborn. We have discussed surfactant deficiency, congenital pneumonia, uh, meconium aspiration syndrome, transient tachypnea of newborn. Congenital pneumonia is one of the leading causes of neonatal respiratory distress and is most commonly acquired at birth. Risk factor for congenital pneumonia, they include congenital infection, preterm birth, and rupture of membrane. So you can see that preterm birth is a risk factor for congenital pneumonia. So that's why if a premature infant present to you with shortness of breath, then you will suspect either a surfactant deficiency or congenital pneumonia. And that can only be confirmed on a chest X-ray. In case of congenital pneumonia, chest X-ray will show patchy consolidation, while in case of surfactant deficiency, there will be bilateral ground glass appearances on a chest X-ray. So until congenital pneumonia is ruled out, we need to start the baby on antibiotics. Pneumothorax and diaphragmatic hernia, they are also causes of infant respiratory distress syndrome. We are all familiar with the pneumothorax and diaphragmatic hernia. It can lead to due to defect in the diaphragm. Stomach is usually herniated into the thorax, which compress the lungs, and thus the baby can develop respiratory distress syndrome in case of diaphragmatic hernia as well. And an X-ray in case of diaphragmatic hernia will show air fluid levels in the chest. So if there are air fluid levels in the chest on a chest X-ray, then your diagnosis will be diaphragmatic hernia. The other hint for diaphragmatic hernia is that if you see a coiled NG tube in the chest, then again the diagnosis will be diaphragmatic hernia. Management of pneumothorax is same as in adults, that is oxygen, needle aspiration, and chest tube for symptomatic infants. Now, a short summary of an infant who is in respiratory distress. What is the stepwise management of an infant who is in respiratory distress? The first thing that you will do is to do a blood gas and oxygen saturation. These are vital investigations that need to be done initially. Next, most appropriate action is chest X-ray, because chest X-ray will help us to identify the cause and rule out important conditions like pneumothorax and diaphragmatic hernia. And after chest X-ray, the other investigation is blood culture, rule out sepsis. Remember that absence of fever does not rule out sepsis in infants. So after chest X-ray, it is necessary that you send a blood culture to see if there is any bacteremia. A short summary of chest X-ray findings of common conditions. Infant respiratory distress syndrome, glass appearance on a chest X-ray, congenital pneumonia, patchy shadowing or consolidation, transient tachypnea of the newborn, fluid in the horizontal fissure. So these are some important X-ray findings that are associated with different respiratory in the newborn. Meconium aspiration. What are the X-ray findings of meconium aspiration? In meconium aspiration, the bilateral lung fields are hyperinflated with non-symmetrical airspace opacities. Non-symmetrical opacities and hyperinflated lungs, if they are present on a chest X-ray, they are usually suggestive of meconium aspiration. So this was all about some conditions in newborn babies that can lead to respiratory distress syndrome or respiratory distress or shortness of breath. I hope it's clear to everyone.
So you said about the X-ray findings of the one of this which you said, like there's a fluid in the fissure. What does that mean? Chest
in the lungs, there are usually fissures. One is horizontal fissure and one is oblique fissure, which separates the different lobes of the lung. So as we discussed that in transient tachypnea of the newborn, the fluid in the lungs that is usually absorbed after birth, there's a delay in the absorption of that. So when there's a delay on absorption of that fluid, a straight line, a straight white line clear?
Yes. So will it show clearly on the chest X-ray? This hello? Hello?
In the internet connection, what were you saying?
I'm saying, like, when on the chest X-ray, will it clearly show fluid in the horizontal fissure?